Hi guys, so now in the part 2 of dysphagia, I'll be talking about esophageal dysphagia and achalasia in detail. So your esophageal dysphagia is of two types, in which only liquid passes and other in which nothing passes. If nothing passes, there is a motility problem, and if there only liquid passes, there is a mechanical obstruction. So now if only liquid passes, there can be different causes for that. If it is intermittent, means it come and goes, then the cause will be ring or VAPS. If it gradually increasing, there must be any stricture or malignancy involved. If nothing passes and the problem comes and goes, the causes will be of esophageal spasm, and it increases gradually. It is achalasia or scleroderma. Now I will go through some important diseases of esophageal dysphagia. Starting with achalasia. In achalasia, lower esophageal sphincter fails to open during swallowing. This leads to the collection of the food in the esophagus, and hence leads to dysphagia. The causes of achalasia may be hereditary, degenerative, autoimmune, and infectious factors. Now, pathologic changes occur, which consist of patchy inflammatory infiltrate of T lymphocyte, eosinophil, and mast cells. This inflammatory infiltrate also causes a loss of ganglion cells and causes myelinic neural fibrosis. This loss of ganglion cell and myelinic neural fibrosis leads to loss of post-ganglionic cholinergic neuron, and which leads to unopposed cholinergic stimulation, causing high basal lower esophageal sphincter pressure. And this lack of relaxation causes aperistalsis over the along the esophageal body. Now, the symptoms of achalasia include dysphagia for solid and liquid, regurgitation, or chest pain. Initially, the dysphagia may be for solids only, and then progresses to both solids and liquid. And the most important symptoms that are most commonly seen is regurgitation, around 75% in 75% of the patient. Choking and coughing can also awake the patient if he or she is sleeping, and chest pain and weight loss is seen in 40% and 60% of patients respectively. Now, how to diagnose your achalasia? There are different type of tests, and the gold standard is manometry, but there are other as well, as you can see, as you can observe it through barium esophagus study. Now, what manometry does? Manometry shows the elevated LES pressure and incomplete relaxation of lower esophageal sphincter, and this also gives the idea of the absence of the peristalsis along the esophageal body. Now, how to treat achalasia? There are several ways. There is surgery for it, or there is drugs. So the drugs are nitrates, calcium channel blockers, nifedipine, and your botulinum toxin injection. So other method of treatment of achalasia, apart from the drugs and your surgery, is pneumatic dilation of LES. It has good short-term results, but it has also the risk of perforation above 2 to 5%. And in this treatment, endoscopy is performed, and which use air to dilate and disturb the circular muscle fibers of the lower esophageal sphincter. Now, the three type of balloon dilators are there that are used to dilate and disturb the circular muscle fibers, and they are of 3 and 3.5 and 4 cm respectively, and they actually causes the relief of symptom in around 50 to 93% of patients. Now, if these pneumatic dilation of LES fails again and again, so there is surgery is performed, and that is your Heller's myotomy. Now, anterior myotomy is done of the LES. In this method, anterior myotomy of lower esophageal sphincter is done. So this is it in this video of dysphagia. In the next part, I will be discussing about GERD. Thanks for watching.